codes, and you need to be prepared on how to respond to those different codes. We'll talk about code blue here in just a moment, but again, this is all about protection of our patients as well as the general public. Code gray refers to security in a medical institution. How are we going to know all these different codes? I mean, there's so many to memorize, right? And each institution will have a code for different instances. This is pretty much universal, but each hospital may have their own different codes. So how do we keep track of all these different, security alerts? Okay. They're usually in the back of your badge. So when they ever announce a code overhead, you just flip your badge back, and that's where it's going to be listed. Okay. Also listed in the back of your card, your ID card, will also be a way to activate any of these emergencies, which may be as simple as hitting a button, dialing 3 numbers, 4 numbers, 5 numbers, 6 numbers. Okay, but that will also be in the back of your ID badge, ID card, also as well as they list all these different codes. Okay, so code gray is security. Once in a while you'll hear this popping up overhead. What they do is, it's simply, I've worked at places where they call it Code Armstrong. Okay, all able and willing and able-bodied individuals come and help because there might be a patient who may be wrestling, fighting. You may have a disgruntled visitor. Okay, you might have a disgruntled family member. You may have a disgruntled patient. Okay, even staff workers. You may have disgruntled staff workers. So we want everybody to control the situation before it escalates. Code red is fire. We're going to talk about this later on, I think Unit 5. Code pink, or code pink secure, is an infant abduction. On occasion, the facility will activate a mock code pink, and this is where you need to be on high alert because of an infant abduction. What we do is we cover all entrances, exits, stairwells, hallways. We secure those areas, and you're supposed to stop and question anybody within your vicinity. Infants have been known to be abducted in coolers, in backpacks, in Nordstrom's bag, okay, grocery bags, okay. Infants are very tiny, and they're very flexible, so you can stuff them in any small area, okay. Code purple for child abduction. Code orange, hazardous material spill. Should we be concerned about that in radiology?
Mm-hmm.
Yeah, because once in a while we'll spill whiteout. You guys know what whiteout is?
Yeah.
Okay, correction fluid. Okay. It used to be that in our department we had a lot of, we had processors in almost every corner in radiology. Okay, the chemicals in there themselves, if we have a spill, hurts when you inhale, because it can cause upper respiratory problems. It can also cause your eyes to tear. So it was not a common thing, but it happened occasionally in the radiology department. But now that we have computerized stations to produce our radiographic images, we've kind of dealt away with that. Okay, but once in a while we'll still have a hazardous material spill. Code green is an incoming heart attack. That prepares the emergency team to be prepared to perform life-sustaining procedures upon the arrival of someone who is on having a full code or full cardiac arrest. Code triage. When you have an internal or external disaster. Can you guys give me an example of a code triage?
Welding.
Okay, say that again.
Earthquakes.
Earthquakes. What else?
Welding.
Explosion.
Explosions. Okay, what else? Train wrecks, right? Airplane crashes, multiple vehicle accidents. This is when the hospital has been put on alert that they will be receiving a multitude of patients. So they also need to be prepared to receive this influx of patients. Okay, what about an internal disaster? We also said it here. Okay, you can have flooding, you can have earthquakes, you can have building collapse. Okay. Code yellow is a bomb threat. Code white, pediatric medical emergency. This is very similar to a code blue. This is code white. We're pediatrics here. Okay? And then code silver is just an extension of this code gray. This is persons with a weapon or a hostage situation. Okay. This used to be not a big deal because it happened just once in a blue moon. But now it seems to be happening more and more and more often. Okay, and then code blue is cardiac arrest. This is somebody who's going into full cardiac arrest and may or may not also be going into respiratory arrest. So here we need to perform life-sustaining procedures to bring this person back to life. Okay, this is a situation that may happen often in your department. Okay, so we'll get into that later on of why this is a common occurrence in radiology. Is there any questions?
Yeah, what's the difference between that one and the, there's another one there.
Here, and then what?
Incoming cardiac arrest?
And then incoming. This is happening in your
Oh, within
facility.
It's already
Yeah,
happened,
this
yeah.
is outside of the facility and then bringing them in.
Okay.
Yes, that's your code green. Okay. All right. So here's your crash cart. This is what contains all the life-sustaining instruments and medications necessary in someone who's having a full cardiac arrest or even a full respiratory arrest or both. So again, it contains emergency medications, supplies, and other life-sustaining equipment. This is how it looks on the outside. It looks just like a toolbox, right? This looks like a toolbox. However, here, in each of the drawers, you will find all the different equipment and instruments as well as medications to perform this life-sustaining procedures. You will also find other things like your cardiac defibrillator. So someone's going into ventricular fibrillation. Have you guys ever heard of that term, VFib?
Mm-hmm.
Okay, ventricular fibrillation. What's happening there is your heart is not pumping. It's moving, but it's fibrillating or going into, okay? It's just there shaking, quivering. Is that good or bad?
Bad.
It's bad because you want your heart to pump. You need to send your blood supply into your vital tissues and organs. If it's just quivering, the blood is just sitting in the ventricles and has nowhere to go. So a defibrillator pumps or shocks the heart back into some type of electrical conduction, causing the heart to beat and squeeze the blood out of the ventricles and out into the tissues and organs. Okay? Now, over here in the drawers, we have locks. Okay? They're simple locks. They're not like padlocks. Okay? They are made out of plastic, so when we need to access the emergency equipment and medications right away, we can easily break that seal. If you had a padlock on there, now you waste valuable time to get that open. Okay? But all it is just a simple plastic seal. Okay? And then you will notice that it has numbers or codes on there. Lot numbers or codes. So that way, when we do our daily check, and when I say daily check, we do it twice a day. One in the morning and one at night. Okay? One in the beginning of the day and one at the beginning of the last shift. Okay? To make sure that, again, that it hasn't been tampered with. So one of the things we're going to do is we're going to look at the locks to make sure that they haven't been broken. Okay. You will also notice that there is a clipboard here. There is a clipboard. It's just a basic checklist that we go through to make sure that we have all our supplies and nothing is missing. So we're checking for supplies. We're checking to make sure that the locks have not been tampered with. What we're also going to do is we're going to run a test on our defibrillator. So we are actually going to cause a shock okay, to make sure that it is pumping out 200 joules. 200 joules of electricity, and that is ready to go. Also checking to make sure that it is fully charged and plugged in. Yes?
So with the locks on the drawers, you have to take the first person's word for it, or do you check the drawers to make sure they're properly equipped?
Well, if they're locked, then
So you're trusting the person whoever locked them the last time?
exactly.
Okay.
And the individual that is responsible for this is either going to be pharmacy, okay, or the respiratory therapy department.
Because
And those are all drugs?
there's drugs in there.
There's a bunch of drugs in here, and also a bunch of breathing apparatus, and
Okay.
we'll go on the next slide.
Okay.
Yeah,
So as rad techs, we don't really go inside those drawers, or no?
we don't.
Okay.
We don't. There is a different type of medication box that we have in the department that is separate from this. It's called a anaphylactic shock box. Okay, so if someone is having a major allergic reaction, we have our own box that we can access when somebody goes into a major allergic reaction.
It's like epinephrine, we use that.
Exactly. Okay, so let's go to the next slide. Okay, so again, you're going to have your defibrillator, your checklist, you're going to have your ambu bag, okay, it's a breathing bag, sharps container, okay, because we deal a lot with needles and blades and things of that nature during a medical procedure. So we got to make sure that we have a receptacle to dispose of the sharp objects, okay. Here's one of the drawers. Now, this is just an example. Again, it depends on your facility, and each of the drawers may contain certain things, but again, this is just an example. One thing, though, is that you are going to have a drawer full of medication. So if someone's having a heart attack, we've got all these different cardiac meds to get the heart pumping, stronger, okay, to balance the pH within your blood, to also provide any type of fluids to the patient. Okay, so we got all these different things. We got vasopressin, which maintains water and constricts blood vessels, sodium bicarbonate that maintains pH, the pH balance, atropine indicated for cardiac arrest, patients suffering from, you guys know this term, bradycardia?
Slow heart rate.
Okay, so it's a slow heart rate. Okay, so if it has a slow heart rate, or in worst case scenario, a systole, what is that?
No heart rate.
No heart rate. Okay. VTAC, ventricular tachycardia, premature ventricular contractions.
I thought lidocaine was numbing.
It is. It is. But we're talking about very, very minute percentage of lidocaine.
Okay.
We're talking about 100% lidocaine. Okay? And I'm glad you brought that up, because there's one instance. Okay, so lidocaine is a numbing medication, but it also prevents premature ventricular contractions and also VTAC. Okay? In my surgical tray, okay, I don't like anybody touching it, not even the doctor. Okay, so when we're performing a procedure, I would rather that he or she ask me what they need and I will hand it to them, rather than them having to take stuff off my table. Okay? One thing, for instance, is I keep all my medications separate on the table. So one of those things that I do put on the side is lidocaine. And I purposely put it off way on the side so you can't accidentally pick it up. Remember, they're all clear fluids, so you can mistake them for being something else. The other thing that I have here on my table is heparinized saline flush that we use to just clean out the catheters and make sure that there isn't any blood clots on my instruments and things like that. And so I have a syringe full of those things as well. There was this one time where this doctor, he would just turn around and start grabbing syringes without knowing what they are. And they are properly labeled, but he just grabs them without looking, and he starts pumping them to the patient. One of those things that he grabs is lidocaine. Okay? One time I caught him, I said, "What are you doing?" I said, "You just put in lidocaine into the patient's blood vessels." Okay? Which again, not a big deal. But then he did it another time, and then another time, and I finally told him, I said, stay off my table. Leave my table alone. I said, if you want something, ask me for it. Okay? So, as a scrubber, you are also in control of your environment. Okay? Remember, a physician just has that special set of letters after their names, which is MD. They are still human beings, and you need to stop them if they are making an error. Okay? So it's lidocaine. And then your main go-to source of medication is your epinephrine. Okay? You guys watch enough TV shows that when someone's having going into a heart attack, and they are out in the field with the paramedics, what is the first thing they ask for? Epi. Give me epi. If they're in an emergency room, what do they ask for? Give me epi. This is epinephrine. Okay? For severe anaphylaxis, it's a vasoconstrictor which increases contractility and blood pressure. So it causes the heart to beat harder. Okay? It makes the blood pressure more stronger, and it also increases the conductivity of electricity in case you have the patient go into a VFib and you can shock them. They're more sensitive to the electrical shock. Okay? Then we have dopamine, which is a vasodilator, and increases the contractility of the blood flow. Now, do I need you guys to know this? Okay? Not until you get into my program. The RadTech program. Because once you get into the RadTech program, now we need to start discussing the medications. Then we also need to start discussing CPR and life-sustaining measure. Okay? All right? So we're going to be spending a lot more time on that once you guys get into the program. Okay? But just be familiar with the different types of meds that are available. Drawer 2, if someone can't breathe, we can open up the breathing airway. We got endotracheal tubes, different types of airways and tubings. Here's another drawer with a, again, more breathing apparatuses. Blood pressure cuff, what else here? Just a bunch of stuff. Airway, backup medication.
For test purposes, should we memorize all this or
No. Again, I'm just showing you guys just to be familiar again what are in the drawers. You don't need to know exactly what's in there. What's most important is that a crash cart contains all the life-sustaining equipment and accessories and equipment, so on and so forth. Okay. Different types of IV catheters, different lines, different solutions. And then in case, we also have a cut-down tray in case we need to crack the chest open. We've done that before. Where CPR is not doing what we need to do, we'll crack the chest open and we'll do a hand massage on the heart until we can get them to surgery. Okay? All right. Crash carts are generally found in procedural rooms where you are performing IV contrast procedures. So crash carts are generally found in procedural rooms where you perform IV contrast procedures. Okay, we'll talk about that a little bit more in detail, in just a few more minutes. Now, these are the most common type of conditions that you will be dealing with as technologists in your department. The most common being shock. Anaphylaxis is just a major allergic reaction, which is a category of shock. Then diabetes. Okay, a majority of the patients that you will be I don't say majority, but a lot of the patients that do come into your department are already have diabetes, so you need to know how to deal with these patients in case they go into a diabetic shock. Our procedures are generally scheduled in the morning, okay? Whether it be some kind of upper GI or lower GI study. whether it be some kind of urinary examination. Okay. All these type of procedures requires that a patient be NPO for a minimum of 8 to 12 hours. Do you know what I mean by NPO?
Fasting.
Okay, fasting, nothing by mouth, anywhere between 8 to 12 hours. And if they are diabetic, again, this is why we do them first on our schedule. Because they haven't had anything to eat or drink prior to the procedure, there is a great chance of them going into a diabetic shock, and you need to be prepared in case they do.
What were the letters again?
Which one?
For nothing by mouth?
NPO.
NPO.
NPO. Okay. Pulmonary embolism. Again, another form of shock. We'll talk about that later. Someone who's having a stroke. Individuals who are having a heart attack or respiratory attack. Fainting, and as well as seizures. So these are the most common type of, again, conditions that you may be facing in the radiology department. Of course, there's a ton more, but these are going to be the most common. But before we do that, let's talk about the Glasgow COMA scale. The Glasgow COMA scale talks about the patient's level of consciousness. Level of consciousness. We like to use the acronym LOC, which stands for level of consciousness. The first thing that you do when you have a patient present to you in your department is you want to assess their level of consciousness. Okay? Are they communicating? Are they responding? Are they following orders? Okay? A person who is ill can deteriorate quickly from being fully aware to a state where he responds inappropriately or not at all to sight, sounds, or physical stimuli. So when they come into our department, we are going to do a baseline assessment, baseline observation. The Glasgow COMA scale is broken down to 3 behavioral categories. We're going to talk about the eyes, the motor response, and the verbal response. And this is the way it looks. This is your Glasgow COMA scale. Each category is worth 1 to 6 points for a total of 15 points total. So it's also broken down by age specific. So on the first column here, you have infants that are less than 1 year. On the middle column, you have children from 1 to 4 years, and then the last column is age 4 to adults. Because each one of us, each age category responds differently to different stimuli. So again, one of the categories that we're going to assess here is eyes. Are the eyes fully open? Okay? Or are they not open but they respond to voice? Or are they not open, they don't respond to voice, but do they respond to pain stimuli? Because when you respond to pain, you kind of, your eyes crunch up. Okay? And so on and so forth, or no response at all. And then also verbal communication. Let's do about adults. Are they oriented and alert? Or are they disoriented? Or are they nonsensical speech? All the way down to no response. The more alert you are, the higher the score. Okay? Then what we're going to do is we're going to add up those 3 categories. If there is a score of 7 or less, okay, 7 or less, you need to alert your physician immediately because they can go downhill from them. It can be an indicator that something is majorly wrong with that individual, and we need to alert the physician immediately, and you need to be ready to perform life-sustaining procedures. Okay? So, get your doctor. Get ready with the emergency card. Now, here's the thing is, you're never ever going to leave your patient alone. Okay? So how are you going to call help? How are you going to get help?
Intercom.
Okay, you have an intercom. There should be a phone in the room. Or what I like to do is I open up the door and I said, code, and everybody hears me, and then everybody rushes to the room. Okay? But you never leave the patient alone. Okay. Here is another LOC. Remember level of consciousness? LOC also stands for loss of consciousness. So look at the context of the acronym. See how it applies. It can either mean level of consciousness or loss of consciousness. So if you have an individual that experiences a loss of consciousness, you're going to ask the patient to state his or her name. Things that are very common, things that they should know. Ask them their name, ask them their date of birth, ask them where they are. Okay, simple questions. Okay, you may ask them who the president is, but never ask them who the vice president is. Because most of us don't know who the VP is. Okay? So, ask the patient to state his or her name, date, address, and the reason for coming to the radiology department. Again, we're asking them simple questions. And check to see if they are responding to the verbal stimuli and that he or she is oriented to time, place, person, and situation. And note any type of unusual responses. Note the patient's ability, again, after they've regained consciousness, note the patient's ability to follow positioning instructions and note movements causing pain. Okay? Anything that is out of the ordinary or anything that is different from your first assessment, you need to start making notes and ask more questions. Okay? Because again, once the patient entered your room, that's where you are creating your baseline. So if there are any changes, you have a baseline to refer to. Okay? You're also going to assess the patient's vital signs and note in chart if not already there. If the condition changes later, for example, patient complains of pains, headaches, becomes restless or unusually quiet, or develops slurred speech, ooh, this is a scary one, develops slurred speech, or change in the level or orientation as the procedure progresses, you need to stop what you're doing and report this to the doctor immediately. A lot of the things that I'm going to be discussing here is, once you notice anything unusual, you're going to stop what you're doing. Stop what you're doing. Call for help. Get ready with the crash cart. Okay? Never leave the patient unattended. Be ready to perform life-sustaining procedures. Okay? Those are the basic things that we're going to I'm going to repeat this over and over and over again with each of these conditions. Stop what you're doing. Get help. Okay? Do not leave your patient alone. Be ready to perform life-sustaining CPR and be ready to assist. Okay? Those are the things. Also, as part of that is you are going to continually take vital signs. We'll talk about that later on. Blood pressure, respiration, heart rate. Okay? These are all baseline data that you need to know before you start the procedure. Because how do you know anything's changed if you don't have your
Baseline vitals.
basics? Okay? All right. So the first condition we're going to be talking about here is shock. Shock is the body's physiologic reaction to illness, trauma, or stress in which there is, now here's the key definition for shock, where there is a disturbance of blood flow to the vital organs or a decreased ability of the body's tissues to use oxygen and other nutrients needed to maintain a healthy state. What is the whole purpose of your blood supply?
To provide oxygen and
Okay.
nutrients.
To carry oxygen and nutrients to your vital tissues and organs. Okay? In the process of perfusion, perfusion is the exchange of gases, nutrients, and waste. Okay? So you're bringing oxygenated blood and nutrients to your vital tissues and organs. It becomes perfused or used up, and then it's returned back into your heart and into your lungs for reperfusion.
Can you repeat the definition of that?
Perfusion is just the exchange of gases, nutrients, and waste.
Good
Okay.
stuff goes in, bad stuff goes out.
Exactly. So that's the whole process of the circulatory system. Okay, we're delivering the goods and removing the waste. It goes back into the heart, into the lungs, and back to the heart again. Okay? So, again, it's going to be a disturbance of the blood flow. Or it could be improper perfusion of oxygen and nutrients. This is what shock is. Because once you go into shock, you can go into organ failure. Okay, we're talking about vital tissues and organs. Okay, we'll talk about the different stages: compensatory, progressive, and then irreversible stages of shock. So the first one here is the compensatory stage. The compensatory stage. I just added on this on for you guys. It's another slide, but I also put it here on this slide. So you have something as a reference when we're talking about our normal range. In your compensatory stage, your skin is cold and clammy. Okay, let's break this down for a moment. If your skin becomes cold and clammy, why is that? Why is the reason why you're warm? Because of blood flow. Okay, your blood is circulating throughout your body. This is what's creating the warmth exuding from your body. If your skin becomes cold and clammy, isn't that an indication of an interruption to the blood flow?
Mm-hmm.
Okay. Number two, urine output decreases. Now think about this, if you will. Urine output decreases. What does it have to do with shock? Where does blood go to get filtered?
Kidneys.
To your kidneys. Okay? And as the blood goes to the kidneys, they become filtered and produces urine. Okay? Urine is the waste, okay, from your blood. Okay? But if urine output decreases, doesn't that also mean there's a decrease of blood flow going to the kidneys? You guys are with me so far?
Mm-hmm.
You guys making sense? Okay. Respiration increases. What does your blood supply carry?
Oxygen.
Oxygen. Now, if there is a decrease of blood flow to those tissues and organs, they are now deprived of oxygen. Yes?
Mm-hmm.
Now, it's going to trigger in your brain, it's going to say, hey, I am not receiving enough oxygen. So automatically what happens is you start doing this. Because now you're trying to compensate for the lack of oxygen, you are going to breathe more.